today's session. As Mishka mentioned, there are a couple of other meetings going on, but I think in the interest of time that we will get started right away. So welcome to today's session. It's been a while. We took a little break for ELSIC, where we looked at various aspects of cancer care on the continent. And so today we're going to be looking at something more specific, something more unique. We're going to be talking about cancer and economics. We know that cancer results in huge economic burdens for the patients, the healthcare system, and countries at large due to, quite a lot of healthcare spending and productivity losses that accrue when patients are unwell. So today we have two eminent persons to talk to us about it. And I'd like to quickly introduce our speakers for today. We have our first speaker, who is Dr. Suja Subramanian. I hope I didn't get that too badly. She's a senior fellow in cancer economics and policy at RTI International and has extensive experience performing economics burden studies, evaluations of cancer screening programs, and implementation science-driven real-world assessments in both the United States and in international settings. She has developed costing methodologies, created micro-simulation cost-effective models, which she has used in the course of her career. She's currently serves as the principal investigator on several grants to access the implementation strategies to enhance uptake of HPV vaccination and HPV DNA testing in cervical cancer. And the second facilitator for today's session is Dr. Rabai Gakunga, who is a research scientist and a research manager who is based in Nairobi. She has over 13 years experience working as a consultant in various collaborations with leading organizations. And in the area of cancer economics, Dr. Kagunga was the in-country consultant for the US CDC study on economic assessments of resources required to report cancer registry data in low and middle income countries. Herself and Dr. Suja have worked together on several studies in Kenya, including looking at cost and affordability of NCD management, and they have jointly published several articles together. So today they're going to be sharing their experience with us on cancer and economics as relates to their work they've been doing in Kenya and across. So I'll hand it over to Suja, who will start and give what we call, often like to call a didactic, where she gives a broad overview. And then we will now take a deeper dive with Rabai, who will share her experiences with costing in Kenya. Suja?
Great, thank you so much, Amaka, for those great introduction. So I'm going to share my screen. I hope everyone can see it. So, okay, yes, good, great. So, and as Amaka mentioned, so I'm going to give a broad overview into what we term implementation economics, to give you some background on the methods that I used and maybe some of the challenges. And then we'll move forward where Rabai will actually provide examples of applications using this type of information. So let me start. So really, why do we do economic evaluation? So broadly, it demonstrates the value provided from the resources expended. So it's really the return on investment that we're trying to ascertain and report out. But public health needs are enormous and resources are limited. So we're always trying to minimize cost while we're maximizing outcomes, but sometimes there will be difficult resource allocation decisions. Some countries like the UK do actually take into account resources when they make decisions on technologies or medicines or any other type of health intervention, whereas other countries like the US actually explicitly prohibit the use of it. So there is a variation across the board in terms of how it's used, but many of the time we're really focusing on the interventions on the ground. So implementation processes are really, really important, but they can be optimized to reduce the cost. So it's not, as you'll see in my presentation, it's not a one-time static type of analysis. And that's where we're going to next. So just want to give you a little bit of background of what we think of in terms of, say, cost effectiveness analysis, which I think broadly almost everyone's heard about, and how we think implementation economics actually differs. So cost effectiveness compares the incremental cost of cost versus the incremental benefit of an intervention. So you can see the ratio there. That's the ratio that's calculated and usually provided. But in implementation economics, we take a much broader perspective because actually this ratio can change over time. It's very different when you're talking about sort of early startup, early implementation, and when you look at it further along in the short-term maintenance or even longer term, there are changes. Both the costs can change, especially because of economies of scale, and the effectiveness also often changes. What you see in an intervention trial is not what you see in the real world setting. So there are these changes that can be taken into account to further sort of to understand and use this more in a, I guess, dynamic manner than just static as a one-time ratio. So the perspective matters. So the viewpoint is something that we actually identify even before we begin any of the analysis. A societal perspective is the sort of very broad. It's probably the best perspective to use, but it's often not used because it's very difficult to collect the kind of data for a broad societal perspectives. So usually you'll see a health system, sometimes even clinic, if the clinic is implementing it, or a payer, or sort of the Ministry of Health perspective. So these are all types of perspectives that can be. But it's important to do so at the beginning because it determines what type of cost you will collect, what you would report, sort of the time horizon of the analysis. Moving forward, just to give a clarification on what we think of as direct cost and indirect cost. So direct costs are those directly related to whatever the medical services or the intervention. So it's in cancer, it will be your screening tests, it will be any treatments provided, etc. And non-medical costs would be transportation, could be even childcare, elderly care, things that you would need to go and seek the care. And indirect costs would be those that are indirectly impacted. So productivity costs, if you have to lose time from work or household activities. And this is a little bit more difficult to capture, but premature mortality and the loss of earnings, it's difficult to capture, but sometimes we've seen this is the biggest cost, especially in terms of prevention and screening, when you can avoid sort of premature mortality, especially mortality among young individuals, because of course they have a whole lifetime of earnings that would be captured here. So we see that when we're working with some youth and other types of young adults, this lost earnings is a very big piece of what the costs come out to be. The time horizon, I mentioned it earlier, so it's the short term versus the long term, and the types of costs will vary. I mean, fixed costs, which we usually say are the overhead costs, things that you have to do no matter what, whether you're implementing for 10, 20, or whether you're implementing short term, long term, but you have to invest. These costs can be spread over time. This would be buying an equipment to do the screening test, those kind of costs. They will vary whether you're thinking whether a short-term project or a very long-term project. And then obviously variable costs generally, just vary with the volume of cases. But it's important to understand and separate out these costs, especially when you're doing the kind of analysis we do in terms of sort of scale up cost and what would really cost to implement at scale. And discounting is the terminology you should know about because you'll see it in economics papers. So usually there's no discount in the short term, but all our long-term analysis have some sort of discounting. And this comes with the, I guess the theory behind this is really that people value money now more than they value the same money over, say, 10 years from now. So that's the kind of trade-off that is done with the discounting. And then finally, a really important piece is really the difference between an accounting cost and economic cost. So accounting cost is just the financial outlay. So to see the example here, if you need 3 nurses and 2 rooms for an intervention, but the nurses are already employed, then from an accounting perspective, you would only include the rental cost of the 2 rooms that you would need. But from an economic perspective, you would include all of these costs. So they're both, I guess, important, but the accounting cost is just what you would need on top. So this is something usually health systems use, but the economic cost is important when you want to compare, say, from one health system to another. It's very different. They may not have the same resources. They may not have the same underlying capacity. So it's really important to also think of economic cost. And the other point of the economic cost is the issue of opportunity cost. Maybe the 3 nurses would have been better doing something else, and we haven't considered that at all. So that's the part of the argument when you're thinking about the economics cost as well. And then I think I mentioned this earlier in terms of phasing, but phase matters. If you're in a planning phase, if you're implementing, if you're in the short-term maintenance or long-term maintenance, cost effectiveness can vary across here. And a very important concept that's been shown empirically in any of these programs is that volume is always a big key driver. So when you scale up, some costs do get lower in terms of cost per case. And that is a huge issue because many times we see that the cost is extremely high in a clinical trial, but when we do our scale up activities, we're actually able to reduce the cost. So it's an important concept to keep in mind for scaling up of interventions. And then also want to just share with you, economics is often considered to be a quantitative science, but actually there is a lot of qualitative work that needs to get done too, just to understand what it is that we're seeing in terms of cost effectiveness ratio or return of investment analysis. So we do a lot of other types of qualitative, like focus group and key informant interviews and other types of sort of market simulation work, which may be just getting information from your end users. It may not be actual data, qualitative data, but we do all sorts of analyses with qualitative information as well. And I just wanted to make sure that's shared. And then finally, I was just going to share some of our evaluation frameworks. This is one of the frameworks that we published in cancer that we're using for all of our cancer work. But it's a mouthful, so you can see it in cancer if you want. So I have a much more dumbed down version that we can talk through. So we start with multi-level interventions, and then we go to what we usually call process measures. So these are like the actual activities, the kids' meal, aspects such as that. Many times we use these process measures also for our implementation outcomes assessment, sort of looking at acceptability, fidelity for sure, those kind of things. The process measures are great. And then, of course, we're looking at the screening continuum just to make sure from screening to diagnosis treatment, because we don't consider just screening and leaving someone as the end. We want to make sure we capture the entire continuum. And then we use performance measures, which is really measures as to how well you're doing with your screening activities. Sort of, is that diagnostic test completed in 60 days, for instance? These are kind of performance measures. And then we have our outcome measures, which are short-term outcome measures, which is really screening rate, et cetera. And then we add on our cost measures, which are our activity-based costs. So this is kind of a process mapping type of approach that we use to make sure we're capturing all the activities involved and all the costs involved. But it's not something we only use for costing, because you can't do economic evaluation without the effectiveness part. So you'll see this captures both sides of the coin here, the effectiveness as well as the cost associated with that. And then finally, I wanted to leave you with the framework for implementation economics. This takes a little bit more broader perspective, but it has very much the same components. We start with multi-level interventions. You have your process measures, but we also add our implementation measures here. So that's very specifically called out. And you have your effectiveness measures in orange here, which is more short and longer term. So you have both of those. Of course, the long term usually requires a modeling study, especially if we're talking about cancer screening. And then we have our cost measures. And then you'll see what we consider sort of implementation economic analysis. We definitely do the short-term cost effectiveness, the long-term cost effectiveness, but we really look at the return on investment as a key part, because we're trying to convince others to adopt and to scale up. That is what they usually want to see, apart from just sort of looking at cost effectiveness ratios. So I think I'm going to stop there, and I will stop sharing and pass it over to Rubai.
You're on mute, Rubai.
Thank you so much, Suja, for the overview, and really appreciate the work that you are doing to help many countries around the world in costing and costing studies. So as I just share my screen. Is that okay?
Sorry, Rubai, we're not seeing it yet.
No.
We're not. Do you want me to share, Rubai?
I
can
And
share.
now?
Yes, it's come up now.
Okay, great. Thank you. Okay, so I'll just go through cost data collection for economic evaluation, and I'd like us just to go through what what cost data can be used for, and this can be used to inform guidelines, and we are looking at resource-based guidelines. You know, when people meet together to come up with guidelines, let's say like for cancer control or for particular cancers, it's always good to have the costing aspect of it, because as you prepare guidelines, we don't always have a blank check, even at country level, at hospital level, even at individual level. So it's good to have the cost so that whenever we come up with guidelines, we have guidelines that are going to work, you know, that the guidelines can fit into the real world practice. I have been a patient navigator for quite some time, and usually when it comes to, you know, just after a cancer diagnosis, you can ask the healthcare provider, so when do we need to start the treatment? And many times they will tell you, we want to start the treatment like yesterday, you know, meaning that immediately. What does that mean to the family and the caregivers and the patient? That means that they have to have some money at hand to be able to start this treatment. And sometimes the patients do not even know what kind of treatment is expected, how much will it cost, where are they going to find it. So when we do this kind of costing studies, we are able to equip the medical caregivers with information that they can pass on to their patients. You know, this is going to cost this much. You can get this treatment in a public facility. It will cost this much. In a private facility, it's going to cost this much. Maybe in another health facility, it's going to cost this much. So the patient and their families are well aware of what is going to happen and how much it is going to cost them. Then we look at now at policy level, policymakers, they need to make a case for funding for cancer control. You know, what is it going to cost to treat cancer, a particular cancer, and even to know further what at the stage of presentation, if it is a stage 1, stage 2, stage 3, or stage 4, how much is it going to cost? You know, and for advocates, it is very good to quantify the cost of inaction. Supposing an intervention is not taken up by whoever is supposed to take it up, what is that going to cost the society at large? Cost-benefit analysis. What does that mean? Cost-benefit analysis can help us to compare the benefits from different industries, even like for healthcare industry, you can compare the cost benefits with maybe the construction industry, road building and things like that. So should the government invest in building roads or should they invest in cancer control? So we need this information as we do our advocacy work so that we can, make a case for funding. And we also need to also know the return on investment. When you know the return on investment, you can much better make your case for funding. So it's also important information that you can also feed into actuarial work. We talk about insurance and insurance premiums. The actuarians need to have information on costing of various diseases to be able to use that to come up with insurance premiums so that they are sustainable. We don't want situations where they tell you to pay this amount of money, then at the end of the day, when you need your services, the insurance company has collapsed. So as an example, I'll give an example for costing. I'm going to just give an example of what Suja, myself, and other colleagues have done. We involved many experts in Kenya, including experts from the Ministry of Health, physicians from different aspects. This was on NCD, so we had cardiologists, we had oncologists, we had palliative care specialists, we had chest physicians, we had diabetologists, and even ophthalmologists, in cases of blindness caused by diabetes, and etc. So our objective was to quantify payments to obtain NCD screening, diagnosis, treatment services in the public and private sector so that we can be able to compare this and also to evaluate the patient's ability to pay for the services. So the targeted diseases, risk factors, and medical services, we were looking at the main NCDs: hypertension, diabetes, cancer, asthma, and COPD. And then we looked at some of the complications: stroke, acute myocardial infarction, angina, heart failure, cancer treatment at different stages, and even hospital admissions for management of acute episodes of asthma and COPD. And the general methodology that we used was, we used a payer's perspective. Suja talked about the different perspectives and what kind of, it varies depending on the perspective that you're looking at, the cost data collected will vary accordingly. So for the societal perspective, it will be quite broad. And then we can even look at the clinic perspective, we can look at the health system perspective, and also the payer's perspective. So in this case, we were looking at the payer's perspective. We developed a detailed detailed treatment frameworks for each NCD and used an itemization cost approach to estimate the payments. And then we looked at patient affordability metrics, which were derived from the Kenyan government surveys and national data sets. And the software that we used was Microsoft Excel. And this really was quite effective. And we know that Microsoft Excel is readily available and it is not expensive. And now I'll just zero in on the methodology for the breast and cervical cancer. So in step one, we developed the clinical pathways, and this we developed from published Kenya guidelines so that we are not far from reality. But to make this better, at step two, we presented these to a wide range of stakeholders just to confirm that we were actually working with what happens in real world practice. And then we also collected details on the number of units of service typically required for each level of disease. And then we obtained staging data from a population-based cancer registry. We did this from the Nairobi Cancer Registry. They gave us information on percentages of patients at each stage, of cancer for both breast and cervical cancer. Then we also collected the cost per unit of service or item that we itemized. And the sources were so varied. We had to look at healthcare providers from the pharmacies, from Kenyan Drug Index to know the cost of various drugs. We looked into the radiology departments. We even went to cashiers just to see what are costs of some of the medications and services. We went to the treatment centers and asked the healthcare givers there, how much does it cost? We went to the pathology departments. We looked at price lists, even if we get like invoices for patients, that was a good source of data. So we used all these data to come up with, itemized cost for each service or item. And the data in step 2 was used to weight individual costs by severity of stage of disease in order to estimate the weighted average cost for each cancer. So there was a lot of work in this, basically moving from place to place, just being able to find the best estimate that we could get. And for the results, for screening, we can see that screening for breast cancer, we found that it was about $3.89 in the public facility. And some of the public facilities, it was much lower, maybe $2.02. But in the private facility, we find that it was $18. And to note here is that some of these costs were basically like at registration or consultation fee. So after registering once, a patient can be able to get other service in the same institution, using that similar registration. But if you just went for you needed a clinical breast exam, then you'd still have to pay that amount of money. And so the pap smear, $10.5 and in private facilities, 25. And then we found that in private facilities, they were not offering VIA billing. Then for diagnosis, we can see for breast cancer in public and private facilities, and cervical cancer, the same public and private facilities. We find that in private facilities, you can see that the service was really high, almost maybe 3 times or so. Then for treatment, we divided this according to stage because the treatment pathways are quite different. And we can see that we even have at stage 3, there are those who take on the curative approach, which is really high, like for breast cancer, it was $1,256 US in the public facilities and almost above $10,000 US in the private facilities. So, and with this kind of information, you can actually advocate for, the screening part. So you see, it's much cheaper when the screening is done and the diagnosis is done early. The disease is treated at an earlier stage. It is much cheaper that way for the individual and even for the entire, country at large in the end, And then we also looked at palliative care. It's important to include palliative care because at diagnosis of a life-limiting illness like cancer, it's important that we have palliative care starting at, at the time of diagnosis. So we went into palliative care, looked at the services they offer, and we found that in a public facility, it was $169 US, and that was for just 6 months. And then for the private facility, it was $752 estimate US in a private facility. This was for just, a period of 6 months. Then for generating affordability metrics, we used key metrics on household expenditure, annual salary in the formal sector, insurance coverage, and annual out-of-pocket payments for healthcare. And we got these estimates from secondary data analysis of the most recent Kenyan National Service at that time. So we had the Kenya Demographic and Health Survey, and we also had data from the National Bureau of Statistics Economic Survey. And this is the information that we found, annual household expenditure, the average was about $413 US. And then we looked at earnings per employee in the formal sector, an average of $6,000 US, both public or private, about that much. And then we looked at insurance coverage, and we found that only about 18% of women and 21% of men had insurance. And then NHIF, which is the National Hospital Insurance Fund, 14% of women, 18% of men. That's a very small percentage of people insured in Kenya, you know. So they are bound to be in big problems when they encounter diseases that are expensive to manage, like cancer and others. Then there was also, you know, checking on the NHIF for the formal sector and informal sector, and you can look at the, you know, the disparities there. 98% coverage for this workforce of the 17%, and then 16% of the 83%. So very few people in Kenya actually have an insurance. And then health insurance and catastrophic spending by wealth quintiles. Wealth quintiles, the quintiles depict, you know, 20%, maybe the general population divided in bits of 20%. So the poorest quintile, only 2.9% had a health insurance. And for the richest, it was 41.5%. Then we look at population with catastrophic health expenditure. Then we find that the poorest were most affected at 8.7%. And even the richest, much as they're in the richest quintile, you still find individuals who are exposed to this catastrophic health expenditure. That is out-of-pocket spending, which is more than 40% of household non-food expenditure. So in summary, what we would say is that there was substantial variation in patient costs between the public and private sectors, and diagnosis and treatment costs, even in the public sector, represented a substantial economic burden that could result in catastrophic expenditures. So we recommend that we should have more of these systematic economic assessments in our healthcare services. And an example of this would be like a question like, what are the benefits gained from the cost expended? You know, we just need to understand the value of what we are spending our monies on. Thank you very much for listening, and we could now get any comments, questions we can discuss.
Thank you so much, Robai, for the very elaborate presentation. We will take comments and questions now. I just wanted to just say a few things about the presentations before we go into it. From what you presented, I guess similar to most other African countries, you know, that are represented on the call, there's a lot of catastrophic spending, especially when it comes to cancer care. So I know Suja mentioned it briefly in her talk, talking about using cancer economics to really show return on investments. As more of our government, or at least some, that are already trying to go into funding cancer care in their various countries, how would you, for instance, the presentation that Robai gave, how can you use that to push the government, you know, to really move forward in terms of return on investments? What metrics really is out there that we can use to, well, for want of a better word, coerce or ensure that our governments actually really invest in cancer care? Because we know, like Robai presented, it takes a lot. Even in the richest quintile that she presented, there was still some degree of catastrophic spending. So how can we move that needle now that we have the data? We've seen how expensive it is, you know, how can we now advocate for more money to be put into the government to fund cancer care? And then even when we do so, what can we ask, what metrics can we offer to the government to show that this is the return on the investment, even as they improve funding in that sector?
Great. No, thank you, Makara. And thank you, Rubai, for doing such an eloquent presentation. So a good question, difficult question to answer, but let me try, because I think the one thing we can do very concrete step is really costing out our guidelines, because all governments, for example, for cervical cancer elimination, etc., these are accepted now. It's not that the governments are saying, no, we don't want to do this. It's embedded in the guidelines. It is there. But the challenge really comes to implementing what is in the country's own guidelines. That's where the challenge comes. And I think costing out these guidelines to say, here's the resources that would actually be required, whether it's a pilot, because many start with a pilot, and then moving on to sort of a larger scale study, I think that's important. We're seeing small steps in that direction. And certainly we are hearing whispers about that in the Kenyan setting. Rubai is involved in those. And I think we will see more of those as we move forward. But I think that is a huge gap where we put out the guidelines, they look glossy and great, but there is no funding behind it because we haven't resourced it. So I think that's like the very first step. And then the second piece is just even understanding what is the treatment cost, because we do offer insurance in some cases, but it doesn't really cover the cost of what it really takes in terms of the various phases of the treatment. So I think just a little bit more research, and then definitely I'm a big proponent of this, is just capacity building. It's not one team, it's not one person or one group who can do this. I think we need to have many more trained individuals in all of the countries we're talking about who can actually do the work required, because it is iterative, it is going to take some time, and we need experts everywhere to contribute. Rubai, do you want to add something?
Yes, I think we, as a country, I think with the studies that we have done, I think we have moved some strides ahead in terms of, costing the interventions. Let me talk about cancer registration, where we also did some economic evaluation on cancer registration. Many times when we are looking for funding for cancer registration, which for a long time has been, no resources have actually been going there towards cancer registration. We've been working with volunteers for quite a long time. So whenever we have meetings where maybe the government or a funder would like to support cancer registration activities, you are asked, so how much do you really require to be able to run a cancer registry in a certain part of the country, in a county, or that kind of a question. So it's important to have some information on how much it costs to run a cancer registry. And if you can have a cost like, maybe $15 to register one cancer case, then you can look at, how many cancer cases do you record in a year? And then you can use that to estimate just how much you would require to have in a year to be able to run a cancer registry. And when you have these kind of figures at hand, then it's easier even for those allocating funds to be able to give you funding for whatever you want to do, as opposed to saying that you want funding and you really don't know how much you require. So I think it's very important for these costing studies to be carried out, not only in it actually at whatever level, at hospital level, clinic level, even county level, the entire government level, so that when we go to the table where funds are being allocated, we have figures, we know how much we want.
Okay, thank you. I think Zipporah has her hand up. Zipporah, you want to unmute?
Okay, sorry for joining. Let's giving a session in another session, giving a session in another webinar. So I thank you, Rubai and Suja, for that study. I think I remember that study being like one of the earliest studies in this country to cost NCDs, and I don't know if there has been another study at that level. So that has been very useful, and for us also it was very useful in palliative care. I just wanted to say that we did a costing for palliative care early this year through a health economist. And the figures that the health economist came up with were frightening. And I think he was costing the first year at about 12 billion Kenyan shillings, and year 5, something like 34 billion Kenyan shillings needed to provide palliative care. And he said that it goes up because the need for palliative care increases because more people are developing, chronic illnesses, and also because of the inflation rates and all those things. And he costed quite a number of things. He costed the human resource, medicines, commodities, number of days with symptoms, home visits, everything that we need to be able to have a comprehensive palliative care service, for example. And so we were supposed to use this costing to advocate for the National Health Insurance Fund USC package to take care of palliative care patients. But realistically, to go to the government with a figure of this amount for one service only, one element of cancer care, was not going to happen, because they would throw it out of the window, saying that we don't even have enough of that kind of amount of money to put into a healthcare system. So you're coming to tell us put this amount of money in palliative care. So this has been a challenge, has been a big challenge, and this report still remains under observation. And we've asked somebody else to look at it and maybe look at different things that could have been costed somewhere else in NCD care or somewhere else, and look at just maybe what it should we really focus on in terms of costing palliative care. So I think costing is supposed to help us do a lot of advocacy in terms of having services integrated, and the government, UHC or NHIF. For me, that's what costing really means for me, that at the end of the day, the patient should be able to access services through not paying so much out of their pocket, because I guess you can never say without paying at all from their pocket. You're not at that level yet, but minimizing the expenditures of the patient, and and all those things. So I hope that this report can one day be useful, the one we did, because it is still at this time we're not using it because it's too crazy. But we are working with Kenya at the KENCO. In KENCO, we're actually working on costing a number of common cancers in Kenya, both male and female. It's something that we're hoping will come out early next year. It's a project that somebody is supporting us to do, and we just want to cost, what does it take for a lady who has breast cancer to access her treatment and all those things. In a simple way that we can actually use this to also advocate for the government, and to include cancer treatment in the UHC package or the National Health Insurance Fund, and even to improve access programs for cancer patients. So costing, yes, I just wanted to say that costing is very important. Without costing, without evidence, without anything, you don't have the government wanting to put in money, because they don't know, they're afraid of what they're going to be doing if they say they're going to take care of all the cancer patients and do everything. They don't have an idea of how much it costs. So costing is very important. And I hope maybe Robai Suja, we can maybe look at really like costing just cancer by itself later on in an extensive manner from prevention, because the government wants to hear about prevention and early screening. That's where they want to put their money mostly. They don't want to put money in treatment because treatment is expensive. So again, looking at how can we emphasize the issue of prevention and early screening, so that we have less people, being treated for cancer. It costs a lot of money to treat patients with cancer. It costs money for the government. It costs a lot of money also to the patient who's trying to get that treatment. Thank you.
Thank you, Zipporah. I mean, you took your last comment, was a question that I was waiting to ask our eminent speakers, talking about how to strike a balance between funding for cancer prevention and screening versus treatment, because we know that both arms are important, but then what do we ask our governments to focus on, considering the high burden that we already live with, that already exists even in our community. But even as that thought, I don't know, I think Suja is preparing to answer that, okay? Because I was going to move on to Kingsley.
Well, very brief, because I think we have other comments as well. But Zippy, thank you so much for your comments, but I think this is issue. Of course, you can do economics, and then advocacy is an art. So it's really what you take out of the economics and are able to push through the political system, or or through policy makers. And usually what we try to do is go for the quick win, right? So something at least out of those, whether it's just certain palliative medicines or certain pieces that, that they're willing to fund in the short term, and then keep the rest of the economic analysis in your back pocket as we move forward and more resources could be available. But it is scary to think about the resources that we do need, because the needs are there.
Enormous, yeah.
They are there and they are enormous, but we have to start somewhere and convince someone to provide those funds. So sometimes those are short bites that we have to take. And then just in terms of the prevention versus the sort of actual treatment, it's always a dilemma. And I think we still need to do a bit of both. I mean, we do need to do the prevention so we can move forward in the future, so we don't have such a burden in terms of treatment. But I think ignoring people who need treatment right now, it is also, from an ethical standpoint and from an economic standpoint, doesn't make sense, because treating people also has sequelae that you have to spend less on sort of morbidity, and certainly mortality among people does have an impact to the economy of a country. So yeah, it's again another hard question, but there needs to be a balance. It's not one or the other. But I will stop there.
Okay, thank you so much, Suja. Really hard question. Kingsley, I see you have your hands raised.
Yeah, thank you, Suja and Rubai, for the excellent presentation and for the work you do. I think, when it comes to cancer funding, especially in Africa, it's really, really a challenging one, because there are just a lot of, demanding things that definitely need funding with very limited resources. But one area I was kind of thinking of is more of local manufacturing of drugs. Especially those that are already off patent, because, as we know, we have effective treatments for certain cancers, but a lot of people do not have access to those drugs. And even if they do, it's really expensive, and they cannot consistently take those drugs. A country like Rwanda has invested in manufacturing morphine, and they hardly have morphine stockouts. So I think that simple example of a success story in Africa can probably be, a case can be made for governments to encourage private investors to and create the opportunity to manufacture some drugs, depending on what the prevalence or the incidence of certain cancers are in those countries, because I think it will save quite a lot of money than just kind of buying directly from the companies. And then the second thing too is, as Zipporah mentioned, the low-hanging fruits, which is basically prevention. So it's much easier and cost-effective to provide HPV vaccines than treating cervical cancers. And the last thing I'll say is sometimes it's very difficult to try to convince a government to fund palliation, given that they're sort of calculating, okay, well, if this person is going to live for, and these are precious lives, but the way the government would think, given their limited resources, would be, well, if this person is going to live for 2 years, or the expected life expectancy is 2 more years, what would be the investment case to spend all this money? So I think it's going to be a kind of a multi-pronged approach. But like you said, from an ethical standpoint, everyone needs to be taken care of, even if it's terminal. And we just have to sort of find the balance. And I think local manufacturing too would go a long way in even solving, or at least attempting to solve some of the palliation, access to palliation issues that we have in Africa.
Okay, thank you, Kingsley. You talked on some very major issues here, so I'll leave it to our experts to chime in.
Rubai, do you want to go first?
Okay, yes, I really do agree, and it's important to reduce costs as much as possible as we increase the effectiveness of our interventions. So yes, true, if we can find ways of reducing costs, that is a plus, and it's very welcome and should be taken into consideration. Yes, and then cancer and other life-limiting illness, those are very emotive issues to discuss, especially if if you are affected or personally, or maybe a loved one is affected. You cannot start talking about the money involved. You just want this person to have the best quality of life and the best care that they need. So those are discussions that have to continue going on, so that people are not just, neglected because they have 2 more years or 5 months. It's very, the ethics around it is very important.
Thanks, Rubai. So if I could just respond to you, and it looks like you've hit a nerve here. So Paulette is also chiming in and certainly agrees with you. And you raise a really important point, because when we're talking about economics, it's not just costing things out, it's to also try to see how you can make the treatments cheaper, and obviously manufacturing within country is certainly a great approach to take. So I agree with Rubai and you and Paulette, and I think everyone on this call agrees that that's the approach, and we hope that more of the countries will take this approach that you already mentioned in Rwanda, and invest, which is also an investment, invest in country manufacturing of at least these off-patent drugs and other technologies. We always hear about just using, needing just sort of implants when you have, breast cancer, or just, the type of bras that we were looking for, and we find that challenging to get. So there's just a lot of different types of things that could be easily, even low-cost things that can make life better, both in terms of the quality and then just extending lifespan. So we'll send it back to you, Amaka. Or maybe Zippy has another comment, I don't know.
Yes, I think she has her hand up. So Zippy, if you can go in 1 minute, we're almost at the top of the hour.
Yeah, I was just going to just say that actually, I think the things that are happening in Africa. Recently, there was the African Medical Agency treaty that was launched, AMATA, that is looking at many things apart from putting patients at the center of everything, but looking at regulating quality of medicines in the African countries, but also looking at the issue of manufacturing some of these medicines within our own country too, so that we can actually ensure continuum of care, of availability, and also low cost of the medicine. So there is some work going on. A number of countries came together and have signed this treaty. So let's hope that this treaty will actually be able to address some of those issues that have been mentioned here, manufacturing medicines by ourselves, and also lowering the cost of these and avoiding the stockouts that we usually have, especially in Kenya here on opioids. Thank you.
Okay, thank you so much, Zippy. Thank you so much to our guest speakers, Suja and Rubai, for walking us through some of the activities around cancer, economics, and costing. And with the excellent example from Kenya, we're almost at the top of the hour now. So I'll hand it over to Mishka. Christine is not on the call, who will take the final announcements. And just so those of us that are on the call know that this conversation doesn't really have to end here. We can continue the dialogue on Basecamp, and our resource persons are readily available to help for countries that are looking into costing. I'm sure they would be willing to help and prefer solutions so that we can continue the conversations off this platform. Mishka?
Thank you, Amaka. Thank you, Suja and Rubai, for fantastic presentations, and to everyone for the discussion today. As Amaka mentioned, for those of you who are not already on the Basecamp portal, you can reach out by email to one of us, and we're happy to join, include you there. It's a great opportunity to, as Amaka said, reach out for additional resources, but also share additional tools and resources you use in your own settings. So our next session will take place on Thursday, December 2nd, at the same time as we are now. And Paulette Ibeka, I'm glad you're here today. Paulette will be facilitating the session, and the session will be focusing around monitoring and evaluation of cancer program implementation. So it's a very good follow-up to today's discussion. So welcome you all to join us then. And thanks to Rubai and Suja, they've given permission for us to share slides. So we'll be sharing those and the recording link after this meeting. So wish you all a very good rest of your day, evening, night. And thank you all again for joining today.
Thank you, and bye.
Thank you. Bye.
Bye, everybody.
Bye, bye, everyone.